do you think we should get started, Kirsty?
Yeah, let's do it.
Yeah, perfect. Okay, well, welcome everyone to today's community practice, which we've entitled Back to School. And for obvious reasons, I think, given the time of year and the fact most people are starting back at school today or tomorrow. But before we go any further, we'd like to start with an acknowledgement of country. So in the spirit of reconciliation, we acknowledge the traditional custodians of the land on which we meet. So I'm currently on the land of the Wurundjeri people of the Kulin Nation, and I think that is the land that most of the ICAM project takes place on. We pay respects to our elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander people today, for they're the safekeepers of memories, traditions, and culture. We recognise their connection to country, land, sea, and community, and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. And then just some Zoom housekeeping. So please keep muted just to maintain, to minimize background noise, but we're hopeful for things to be as interactive as possible. So please ask questions in the chat box, and also tonight, to try to make it more interactive than previous COP sessions, we're going to trial using some audience polling. It's not, the purpose of the polling is not like a test or checking if people know things or anything. It's just to try to make the session a bit more interactive and engaging rather than just the presenters talking a lot. So that people who can't make it this time can view this. The session's being recorded, and please ensure that you join with the name that you registered with so that the team can mark off your attendance. That's really important for CPD and that sort of thing. In terms of if you do need to change your name, because sometimes Zoom defaults you to something else, there are instructions on the slide. I'll just leave that up for about 20 seconds so that people can follow those steps if needed. Okay, and so then today, in terms of the agenda for today, we've got a few things. As you'll see, Kirsty and I are going to tag team a bit, so to cover a few different topics, but we thought we'd start with a kind of case discussion to set the scene. Then I'm going to talk a bit about exercise-induced asthma and really about teasing respiratory symptoms related to exercise, how to differentiate asthma versus other causes. So hopefully that's clinically quite useful. And then Kirsty's going to lead the discussion around asthma plans, and really we're hoping this is going to be as interactive as possible. And then touch on health pathways and community asthma program. But with the asthma plan section, I think that's really going to be a good amount. There'll be time for discussion, and we're hoping that there'll be lots of discussion about the role of schools in asthma, because we know that's really important, and how we can, as people with asthma and families with asthma and health professionals looking after people with asthma and schools, how the three arms can all work together as well as possible and promote good asthma care. So with that agenda in mind, these are some of the learning outcomes we hope we will be able to achieve by the end of this session. And so, as Kirsty said, we've got the biggest enrollment for an ICAM yet, and I think we're up to about 50 people attending. So if you wouldn't mind in the chat writing your name, organisation and role, that just helps us to, and everyone else who's on, to know who else is in attendance and what people's background is. And I'm going to have a look at the chat.
I'm just sitting here typing to everybody while you're talking, Shiv.
Oh, cool. Thanks. And then I think people are probably maybe sick of my voice already from previous sessions, but just to introduce myself again. So I'm Shiv. I'm a pediatric respiratory specialist at RCH who does a lot of asthma work, and I love this forum because I love kind of getting outside of the walls of RCH and speaking to people working in asthma and other settings. So it's really great. And I might, Kirsty, I might let you introduce yourself now as well.
Sure. I'm Kirsty. I'm a GP. I work over in Truganina in Melbourne's West. I'm passionate for all health, but especially PEDS. And due to the high volumes of atopy and asthma we see, I have developed an interest in that area.
Excellent. All right. Well, thanks everyone for introducing yourselves in the chat. I think it looks like we've got like a really nice mix of people from different practices and hospitals and from different professional backgrounds. And I think I even saw some like lived experience as well with maybe someone being a parent of someone with asthma or yeah. So anyway, I think it's great to see that variety, and really hoping that there'll be a good discussion where we draw out that. So without further ado, I'm going to stop sharing, and then Kirsty will take over, and we'll just start with a case study.
Fantastic. Thank you so much. Right, bear with me, folks. I'm not the most tech savvy, so I'm going to try and share my screen and get to where Shiv left off. So I'll be running the case study this evening. If you're new to the community of practice, please feel free to write any questions that you have in the chat. We'll have Shiv and a few other people looking at them. There are no silly questions, and we'll just find a convenient pause to answer them. I will be pausing for specific questions. Feel free to put your hand up as well via that method, and we can have a chat as well. It's a very informal, open discussion, and we love everybody's opinions. Okay, so can everybody see my screen okay? It should say case study 1. Fantastic. So these are real life case studies. For anybody else working in the community at the moment, I'm sure you will be flooded with requests for asthma plans at the moment. Our back to school community of practice was inspired by the difficulty in this time of year with managing those requests and balancing good asthma care and review of asthma. Sorry, 2 seconds. I have a small asthmatic child here who's coming as well. Hey, darling, we just one thing. That was an example of some fantastic parent management by myself and my other half. So feel free to come and book an appointment for parenting techniques from me as well. So this was a family of 3 who were new patients who turned up in my practice just last week. Recent move back to Melbourne from Queensland, came in with mum. All 3 presented me with the historic Victorian schools asthma action plans, saying they were starting new schools and school had required them to have them filled out before they attended. So we'll start with case 1. He was a 14-year-old male, as said, asking for a new action plan. Taking a bit of a history, mum said he'd been diagnosed with asthma in preschool. He'd had wheeze and viral infection, and he'd really just used Ventolin as required since then. He did use a spacer, and they seemed well educated on it. Never had any admissions, never given any oral steroids or antibiotics, and never required a preventer. He had self-managed his Ventolin use since 12 at school, and mum encouraged this at home as well. But he had noticed an increased use at school, especially in sports. Reported he was breathless after a few minutes running. He felt tight in the chest, but had no cough, and he wasn't really sure if he was wheezy or not. He takes the Ventolin when he's breathless, and he's not entirely sure if it's helping either. And he reported his main exercise was rugby. Brief past medical history, he was also diagnosed with autistic spectrum disorder, age 7, anxiety, he's got NDIS funding, and he had a history of childhood trauma, hay fever, and rhinitis. So given that brief history, in the world of clinical work, we're obviously formulating, what do we think this is? What are the main needs here? So I'd move on and ask if we can put the first poll up. There are no wrong answers, just what's your strong feeling here? Can everybody see the poll question? It's not coming up for me.
Hasn't come up for me. There it is.
There we go. So do we think this is asthma, including exercise-induced asthma? Do we think it's anxiety, or do we think it's related to physical fitness? bearing in mind it could be all three of these things, but what's your feeling here? Okay, that looks like the poll has stopped. Thanks everybody who participated. A few more coming through here, but most people feel this might be asthma, including exercise-induced, a few thinking it might be anxiety, and a few think it may be related to physical fitness. Hopefully, if I say sure results, you should be able to see the results there. Fantastic. All right, so you're starting to formulate what's going on here. We're going to the next stage of questioning. Does anybody else have any further questions that they want to put up in the chat that they may be asking this family to try and figure out what's been going on and what you're going to put on the asthma plan? Okay, while everybody's having a think, I'll let you know some of the things that we ask. Oh, here we go. Has he used Ventolin before exercise? Great question. No, never. Okay. And while we're talking about exercise, I asked a few more questions about exercise because I could see Mum sitting in the background being very good and letting him answer all his questions. He said that he played rugby. Actually, he hadn't played rugby for 7 years. He doesn't really exercise at all. He spends a lot of his time at home gaming and doesn't really do any sort of physical exercise. So when he does do PE at school, he does find that it's the only exercise that he's getting in a week. Loretta's asked, do they have any allergies? He does get hay fever. Surprisingly, he found his symptom control was actually better from moving from Queensland to West Melbourne. And he does definitely have symptoms of rhinitis, however, and is sitting constantly sniffing in practice. Yeah, Amy, brilliant. Hay fever, how is he managing it? They're not taking anything, really. Okay. And a few other questions that we were thinking of, just standard asthma questions. Vaccines, they can't really remember if they had the flu vaccines. They've had some COVID vaccines. They've not had pneumococcal vaccines. Oh, someone asking for me to show the history again. Yes, certainly. Brilliant question. When was the last spirometry? That's the history again there. Never had spirometry, so brilliant question. So a few other questions as well, things are coming through is, Mum said preschool wheeze, and often we get this history that it's early childhood wheeze. And when you ask a teenager, sometimes they don't really know what you mean by wheeze. So question I always ask is, have you ever had a clinician say he's wheezy and given a Ventolin and the wheeze has gone away? A really nice firm diagnosis of asthma there. Just having a little look through here. And
I think
someone
the
asking about
last comment
pediatric
was
asthma
about
nurses.
inhaler.
Oh, sorry, Shiv.
Oh no, I think that comment we've sorted, and then the
Okay,
last
good.
comment was
Okay.
about inhaler technique.
Yeah,
checking inhaler technique.
absolutely. Yeah. Did you bring your inhaler and spacer with you? The answer is no, every time. So we're obviously already booking a follow-up appointment. How confident are you for teenagers? Are you confident? Do you feel supportive? Do you actually know what you're doing here? What about outside school? If you're running around with your mates or weather changes, do you use your Ventolin there? And then at that point, I tend to stop and think about teeing up the second appointment to get through the business of the day. So from taking this history, the initial was, it sounded like he had preschool asthma and exercise-induced asthma. I agree with the poll results. Taking a bit more of a history, actually, this boy's pretty inactive. He doesn't really exercise at all. And I'll let Shiv go through exercise-induced asthma in more detail after I've done the case studies. But I was actually starting to form the opinion that perhaps this was a physical fitness thing. He'd never been to the GP wheezy, he'd never had admissions. No GP had really heard him wheezy since he was a child and having viral infections. So I was thinking this child's coming in with an asthma plan for school. Does he even still have asthma? There wasn't much in the history that I was completely convinced was asthma versus physical fitness. So the next steps. What are your next steps? Someone obviously said checking inhaler technique. Of course. Are you taking the medications correctly? Asthma action plan. Do you do an asthma action plan? At this point, yes, I don't know this patient well enough. I've taken a history. It's reasonable to do your asthma action plan for school with Ventolin on it as required. And as somebody sensibly mentioned before, perhaps trying it before exercise. And then the other thing, which again, Shiv will speak to a bit, is doing an exercise trial. So really trying to nail down those exercise-induced symptoms, which again, Shiv will go through. We've got a few other good suggestions here in the chat from Mel. Does Ventolin actually work for him? We're not really sure, and that's why I often get to do an exercise trial. So I'll let Shiv go through what he advises. Sometimes what I'll say to people is, go with your parent and your spacer and your inhaler and have a run around a field, kick a ball, do something that makes you a bit breathless. And if you start to feel breathless, stop, see what happens. If you're obviously coughing, wheezing, unable to speak sentences, it's probably asthma. Take your Ventolin, see if it works. If actually the breathlessness settles down after a couple of minutes, you're no longer breathless, it's probably not asthma. And if things settle down their own, have another run, see if the same thing happens. And then you sort of build up an opinion, is this actually exercise induced or is it physically induced? So we made a plan that we would do the asthma plan for school, put Ventolin on it. We'd refer him off for some pulmonary function tests to the Royal Children's, and we'd see him back in clinic. And based on those results, we would do a referral to the community asthma programme, which we'll talk more about. And we would consider setting up a care plan, which somebody mentioned in the chat, obviously for his ASD and services, but also for his asthma, and reviewing that diagnosis. Somebody's also said, take the Ventolin clinic in front of the doctor and see the results. Absolutely, that's some of the advice I ask people to do the most. And mostly his symptoms were in exercise, so it's pretty tricky. We do have a field next to our clinic that he could go run around, but it is a bit tricky to do that in practice. If anybody's got any good ideas, that's fantastic. But yeah, I do encourage people, if they are coughing or feeling tight in the chest, to try and get to the GP for us to auscultate. Any other questions about that case study? So I should say, I don't have answers for any of these kids. I saw them 2 weeks ago. It's more to represent the variance in asthma presentation when they turn up on your doorstep asking for an asthma plan. I suspect this boy has mild asthma and that he possibly has an exercise component. But it's very likely that also that he may have outgrown his asthma diagnosis. So case 2 was his sister who came in, also asking for an asthma plan for school. She was also diagnosed with asthma and preschool wheeze and viral infection. Now, slightly different, she had had several courses of oral steroids between the age of 5 and 12 for wheezy episodes in the community. Mum reported she had had almost 4 to 5 oral steroid courses for 3 days every year for the last 7 years. So we did a calculation and that made about 90 days worth of oral steroid between the age of 5 and 12, which is a huge oral steroid burden. She'd never been prescribed a preventer. She remained on Ventolin as required via spacer, which she used, and she had a home Predmix prescription. They reported that her last exacerbation 5 months ago, and this was in Queensland, not locally, so we couldn't corroborate it. They'd attended ED and she'd required more oral steroids, oxygen, and burst therapy. However, she'd been discharged after 2 hours. They reported that she'd an increasing Ventolin use several times a week, waking tight-chested since moving back to Melbourne and since moving to high school last year. She felt breathless and would be gasping, lightheaded, and even passed out a couple of times. She didn't cough, and she does feel that she's wheezy at the time. She has a history of cat allergy, rhinitis, and hay fever. She also has a complex history of PTSD and childhood sexual assault. She has anxiety with multiple somatic symptoms that she's been hospitalized for, and she's recently been started an SSRI. Social history, they've just moved to Melbourne, and she's had 5 school moves in 7 years. So I'm going to move to the poll question. If we can put up the poll question again, who thinks this is asthma, anxiety, or physical fitness? Now, again, we can have more than one diagnosis, but the predominant issue here with this girl, do we think it's asthma, anxiety, or physical fitness? Seems to be roughly even Stevens at the moment. Stephen, I'll take your question on hold for how often do you insist on spirometry to confirm diagnosis. I'll let Shiv answer that during his section. Okay, I think that's most people answered. You can see there, slightly more people feeling asthma, slightly more people feeling, slightly less people feeling anxiety. So I'll go back to the history. So any more questions you'd want to ask about this girl? Brief summary is she's definitely a preschool, asthma. She's apparently had a recent admission to ED that only lasts 2 hours, but she did need steroid and oxygen, which to me didn't sound quite right. And she was hyperventilating to the point she could pass out. Obviously a complex mental health history as well, and symptoms in the morning, and predominantly at school. Someone said, giving the response to oral steroids, she may have allergy-related illness. Well, that's interesting, isn't it? We see a lot of oral steroid use in the community, and I couldn't really pin down how much she did actually respond to oral steroid. There was an awful lot of phone calls over the COVID period being given over oral steroid, being told she was asthmatic. And not too many times, again, the crucial question, how many times has she been auscultated to be wheezy, given medication and seen to respond? Not too many times. It was often going in, saying she was breathless, saying she was having an exacerbation, using more Ventolin, and being given a script for oral steroids. Great question. Does she like her school and teacher? Not much. She's not there for very long enough to move on. So you have 5 school moves due to various factors: bullying, not working out, house moves in 7 years. So she's never really built up consistency with school. Someone saying, yep, may need a preventer. Someone else saying, give a preventer. What brings on the asthma symptoms? Yeah, really good question. Whether exercise, not so much, viral infection, not really anymore. She said she didn't really know. It could just happen. And definitely waking in the morning, she always felt quite tight in the chest and instantly reached for her Ventolin. And a lot of times at school, she said it just came over her, was her description. A lot of people saying preventer, how do you respond to the SSRI? That's another discussion. So not very well so far. Certainly no difference in our asthma symptoms. Amy's saying do an asthma score, ask about allergies, hay fever, triggers, stress, chemicals. Yep. Yeah. Great. So really, really good suggestions there. So again, my first thing was set expectations, said, look, that's going to take a bit of time to figure out. We're probably going to have to book in some long appointments. So I scheduled 2 further 20-minute appointments to chat through all this. The first to deal with the asthma and the second to deal with all the other issues. So she hadn't brought her inhaler or spacers. So we obviously brought her in back to do that. And I agree. I thought, you know, I don't have enough of a history here. I don't have any corroboration, but this is a child who's had an enormous dose of oral steroids. And reported admission within the last 6 months and constant use of her Ventolin. Really, she needs a good go of the preventer. So that's what we did. We decided to start her on Symbicort because she was 12, according to the most recent GINA guidelines. And as opposed to doing the Victorian Schools asthma plan, which we'll talk about in a little bit, we did a smart therapy asthma plan. And again, I'll go through all the asthma plans in a little bit, and educated her on using the Turbohaler as opposed to the Rappihaler, which is a bit more convenient and requires that she doesn't need to take the spacer to school. I put her on for a review a week after she started to see how she was getting on. Crucially, when I did the asthma plan, as you will all know, often the plans are brought back governed by the date at the top that says this plan is reviewed by, and that's when the school says it's run out of date, you need to come back. So I made sure that I did a review of the plan in just 3 months to trigger the parents, one, to bring her back in. Hopefully we'll see her before then, but also so they had that extra thing from the school saying, actually, your plan's run out, you do need to come back. And often I'll use that to help remind people if they have forgotten to come back in that really we need a sooner review. They can't just wait for a year for us to go through this. And then our referrals. So this is a kid who we definitely did a care plan on. We referred to the Children's for pulmonary function test to try and really nail down whether there was any reversible obstructive airway disease. We referred to the community asthma plan, which will asthma program, which we'll talk about in some more detail. Obviously, addressing her psychological symptoms. She hadn't had therapy for over a year as well, which correlated with her increase in Ventolin use. And we really thought about how do we engage school in this complex young lady who's hopefully moved back for good and will be attending one school now for her high school era. And again, we have a section later on to discuss how we actually engage schools in these complex patients and how we're going to get really good communication about her Ventolin and anxiety management, her Symbicort and anxiety management during the school day. So a few questions here. With Symbicort PRN, what frequency do you advise patients? Oh, there's shit, brilliant, yeah. So for this girl, I put her on low-dose Symbicort twice daily. And so I started her on regular therapy due to the amount of steroid in the recent hospital admission and also her huge amount of Ventolin use. So yeah, I said 1 twice a day. We'll review that and as required. And you'll see on the smart therapy plans slightly later on in the presentation that any more than 6 inhalations a day triggers seeing your doctor, as opposed to the 2 inhalations of Ventolin a week that should trigger you to see your GP. Any more questions regarding that case? So yeah, my feeling was she definitely has asthma, but a lot of the presentation was anxiety predominant as well. So really tricky to need out what is anxiety and what is asthma. Okay, so case 3, her brother, 10-year-old male, again asking for an asthma plan for school. And this one was a bit more straightforward. So he was again diagnosed with asthma with preschool wheeze and viral infection. He did oral steroid twice a year for wheezy episodes in the community that he'd been seen by the GP for. He didn't have any admissions and he did a couple of oral antibiotic courses. He was using Ventolin as required via spacer, but he was using it more than twice a week regularly. He had about 4 or 5 exacerbations a year, requiring a few days of increased Ventolin use. He had moved from Queensland to Melbourne and had an increase in Ventolin use since moving due to cough, being wheezy outdoors. And Mum said there was a clear response when she gave the Ventolin. He still needed help with technique and when to use it. And his history was a strong history of A to B. So same again, any further questions for this child? Same as last time, we're talking about vaccinations. Have you brought in your inhaler and spacer? Nope. So we'll have to check that out. AAP we've asked about, we're going to have to manage that. And really this seemed a little bit more straightforward. I'll ask the poll if I can get that up. Yep, everybody said asthma. Everybody feels it's asthma. A bit more straightforward. These are the consults we go, oh, you've got asthma. Great. So he was a child, though, that really it sounded like he was using Ventolin for pretty textbook asthma. He was having 4 to 5 exacerbations a year and at least 2 courses of oral steroid in the year. Who would consider starting a preventer on this child? You can pop it up in the chat. No one? Okay, I did. There we go, Shiv, yay! Yeah, family history. So all the cases are his siblings. Mum doesn't have asthma. Yeah, so we started a preventer. So we talked about starting Flixotide, low dose, 1 puff in the morning, 1 puff in the evening, and I brought him back for a follow-up appointment, checked the inhaler technique, talked about when to use before brushing your teeth. So you're rinsing your mouth out afterwards, talked about side effects, and set up his asthma plan for school using the Asthma Australia Action Plan. And that was pretty straightforward. So really those cases were just to exemplify how 3 kids close in age, all within one family, presenting with asthma, and the typical thing, have been given a piece of paper for us to fill out, and we're expecting it to be a straightforward Ventolin, Ventolin, Ventolin down all the plans. One actually, their plan was on hold until we'd figure out whether there was still asthma. One was put on a preventer and used a SMART action plan because age appropriately she was 12. And according to the most recent international GINA guidelines, we should be starting children 12 and over on Symbicort, and that is as a preventer and also as required, so PRN as opposed to using Ventolin PRN. And then trying to tease out between those 2 children who is exercise-induced or physical fitness, how to manage a child with severe anxiety and asthma symptoms, and then a nice straightforward case of asthma to finish off the I'd say 30-minute, but really it was about 1 hour and 20 minutes worth of consultations. So someone's asking, will we get a copy of the Q&A in the chat? Yeah, the resources and things get emailed out if you've registered. Any other questions regarding the case studies? Okay, if not, I think I will hand over to Shiv, who will clarify exercise-induced asthma for us all, and when to and how to treat it, and when to suggest that this is actually a physical fitness thing.
All right. Thanks so much, Kirsty. I reckon that highlights, like, on the surface of it, asthma is pretty simple, but then it can be much more complex, but usually with a good history, you can work it out. So I think it's, but yeah, that scenario definitely highlights the complexities of asthma at times. And yeah, for people who want more information about, there are a few questions about using Symbicort PRN. We've tried to develop quite a few resources to support that. So there's a learning package that I put a link to in the chat. The clinical RCH clinical practice guideline and the CPG and the health pathways should both have helpful information on that. And exactly as Kirsty said, I would highly recommend it in your patients 12 years and older as the way to go. Okay, so exercise-induced asthma, I think it's worth talking about a bit, and we're going to start off with a poll question. So young people presenting with exercise-induced shortness of breath is relatively common. And hopefully the question pops up about some of the things that you ask for on history that help you to differentiate what the potential causes might be, or if it's going to be due to asthma. So hopefully you can see the poll and you can answer. I can see some answers coming through. So yeah, the options are duration of exercise prior to symptoms starting, what happens to the symptoms when exercise stops, duration of symptoms post-exercise ceasing, and what does a bronchodilator do? And most people are choosing all of the above, so they factor all of those things in, and which is exactly what I would choose. And so that's good. And so maybe you don't need to listen to what I'm about to say, but hopefully you still find it useful. So I'm going to stop the poll. I'll share the results, so hopefully everyone can see those results. So yeah, most people chose all of the above, which I would agree is the right answer, and we'll go through why in a bit more detail now. So let me go to my next slide. So obviously, people presenting with exercise-induced shortness of breath, I think is very common. It's certainly very common for me in my practice, but I suspect even more common for people who work in the GP setting or in the community. And whenever a symptom is presented to us, we always think about the differential diagnoses. And I think the first thing everyone thinks of is asthma. But obviously there are other differential diagnoses too. So for example, I'm very unfit at the moment. So if I went for a run or even up a few flights of stairs, I get short of breath. And that's not because I have asthma, that's because I'm unfit, or deconditioning is maybe a nicer term. But other things, and I'd say that's very common for a lot of people. But there are also other things like anxiety and things like vocal cord dysfunction. So there are other causes of exercise-induced shortness of breath too. And I think it's really helpful to be able to recognize what is asthma and what is something else. And to help kind of explain that, I thought it might be useful to share with you guys the results of an exercise challenge test. So I know there's a lot of I'm going to explain to you what this is, but this is the report that we get, or that anyone gets, if they refer someone to the respiratory function lab for an exercise challenge test. And so the purpose of this test is to look for exercise-induced bronchoconstriction, which is synonymous with exercise-induced asthma. And I think the results are actually very informative and kind of help us to learn how best to take a history to look for exercise-induced asthma. And so what happens in an exercise-induced challenge test is someone comes in, they do spirometry at baseline, and that's in this graph, that's the blue line. So I'll kind of trace it out for you. So that's a pretty normal looking shape there. And then what happens is they have to exercise, and they exercise for, the protocol says around 8 minutes. 6 of those minutes should be above 85% of their maximal heart rate. So they actually have to like do really solid exercise, like really push themselves to extremes. And they have to do that for almost 10 minutes. So it's a fair amount of exercise. And then once they've done that, they stop and they do spirometry. And they do spirometry at 1 minute post-stopping exercise, 5 minutes post-stopping exercise. Sorry about that. 10 minutes post-stopping exercise, and they can keep doing it every 5 minutes up until usually you'd stop at about 30 minutes. And what we're looking for is to see what happens to their FEV1 and whether there's any change. And so this person here has a very typical result. And what has happened is, so their baseline lung function is obviously, it's 100% of their baseline. So they're at baseline before they exercise. And then when they stopped exercising, there was a slight fall, but so 1 minute after stopping exercise, they were about 2.5% down, so 2.7% down. And then 5 minutes post-exercise, they were about 5% down. And then 10 minutes post-exercise, they were about 14.5% down, so here. And once you kind of tick over 12%, that's what we say is a significant drop. And so because they met the threshold for a significant drop, they were given bronchodilator. So that's what happens. They were given Ventolin, and then their results were reassessed. And so this is the post-bronchodilation result. And what you can see is that it's instantly returned to normal. So again, if we look at that in another form on the flow volume loops up the top, well, blue is the baseline value. Red is what happened after 1 minute after exercise, so a little bit worse. Green is 5 minutes after exercise. Orange is 10 minutes after exercise, so a lot worse. And then purple is after a bronchodilator, so back to normal. And so I think what this tells us is very helpful. So the first thing I would say is that it shows something that's very characteristic of exercise-induced asthma, in that you need to do a lot of exercise to trigger it. So this is someone who's needed to run at pretty much capacity for 8 minutes. So, nearly 10 minutes to trigger the response. So you need to exercise for a while before you will trigger exercise-induced asthma. And then secondly, what you can see is that when you stop exercising, things actually get worse over the next 5 to 10 minutes rather than getting better quickly. And then they get better very quickly with bronchodilator. So I think that's really helpful, because if you think about someone like myself who's unfit, who gets short of breath, what will happen is I'll run. If I push myself to maximum intensity, I'll probably get puffed out very quickly, so within about a minute or two. And then if I stopped exercising, I would get my breath back really quickly. So rather than things getting worse, it would actually get better, and Ventolin would have no effect. So you can see that they're two very different patterns. And I think that they help us to use, I use this to highlight that we can use history to kind of identify exercise-induced asthma. And Kirsty, I can see your hands up. Oh, you're muted.
Apologies. Good question and timely question from the chat there. Do you have to be absent from a bronchodilator for any period of time prior?
No, not really. I mean, it's probably best not to take it within an hour or two before, but because you're doing exercise to provoke it, like having taken a bronchodilator 12 hours before is not going to matter. The thing is, and I will hopefully, as I'm going to explain using this table, I don't think you need to refer everyone for an exercise challenge test. And in fact, I very rarely do them, but I think that that's a nice tool because it helps us to work out how on history we can separate exercise-induced for asthma versus other things. Because actually you can make the diagnosis on history or repeat history taking, as I'm going to explain in a second, in the vast majority of cases. Stephen, the x-axis numbers do not line up. Is there a reason? Let me see if I can work that out. Oh, I see what you mean. I think that they do probably. So I think the 10 point is there, and that's lining up to that dot point. So I think that they line up. But yeah. Anyway, so there we go. So I very rarely do the test, but hopefully that was helpful to see in pictorial format what happens. So these are the kind of questions that I ask though when someone comes in, and they'll often say, "Oh, I have really bad exercise-induced asthma. Can you help me?" And the first step is to go back and go, well, is it actually exercise-induced asthma? And these are some of the questions I ask. So I say, well, how long do you exercise for before the symptoms start? So a classic question might be like, well, tell me what sport you do. Oh, I do netball. Okay. So in netball, do you tend to get your exercise-induced asthma? Does that tend to happen during the warm-up, or in the first quarter, second quarter, third quarter, fourth quarter? And it tends to be in people who say, oh, it's the start of the warm-up, I often can't even play the game. Then that's, in my mind, that's too quick. Whereas it's people who are like, oh, first quarter is great, second quarter is great, third quarter, I'm struggling and you often need to come off from my Ventolin. That's where I'm like, okay, you've actually exercised enough that you could have triggered an asthma response. Then also I ask, like, what happens when the exercise stops? So in someone who's unfit or deconditioned, you usually can get your breath back pretty quickly. But as you can see from the previous slide, people with exercise-induced asthma, like over 5 to 10 minutes will get worse. So, and actually if they don't get a bronchodilator, they can keep getting worse and worse. So often what someone might say is, oh, well, like, say if they've been at footy training and they've been running around a lot, they get really short of breath. And then actually I noticed that they're like breathing hard and they're wheezy in the car ride all the way home. And then, when we get home, I've got some Ventolin at home, I give them Ventolin there and it helps them. But, the half an hour car ride home, my child's wheezing next to me, like that's a sign of someone with exercise-induced asthma. Whereas someone who's just kind of is like, oh yeah, it feels really bad, but within 2 minutes I'm back to normal. That's not asthma. That kind of, and actually, like, things get actively worse when you stop exercising in someone with asthma. They don't even, and so that's that. That also kind of is a relation to the duration of symptoms post-exercise. And then the effect of a bronchodilator. So Ventolin or salbutamol or budesonide formoterol in the older kids will always help exercise-induced asthma, whereas other causes won't be helped by bronchodilator therapy. Why I put an asterisk here is that like there's a placebo effect, right? So for example, if I'm really unfit and I stop exercising and I was always going to get better in the next 2 minutes because that's what happens when you're unfit. If I reach for some Ventolin and take a few puffs of Ventolin and that process takes me about a minute or so, then I'm going to think, oh, the Ventolin's really helped me, but actually I would have got better myself anyway. So I say that the effect of bronchodilator therapy is unhelpful, but it can sometimes help you via other means. And then other features. So if someone's like audibly wheezy, that makes the diagnosis a bit easier. But that's, in my experience, hard to tease out. And then in other causes, sometimes people complain of stridor or throat pain, and that's not going to be exercise-induced asthma. That points more to a vocal cord dysfunction cause, and that's not asthma and probably something that they should be referred on for. And so what I often on history, you can tease this out. And then sometimes though, like parents and young people haven't paid that much attention because they've just always assumed it's asthma. So why would they pay attention? That's fair enough. So in that situation, what I do is I give them some homework. And actually speaking to Kirsty, I think she does something similar, and I know other people do too. And so what I say is, I'm not sure if this is asthma or not. I'm not going to make any changes to your therapy today. But what I want you to do is go out and I want you to run around an oval, or next time you're at footy training, or next time you do cross country, like really pay attention. And these are the things I want you to come back and tell me about. And that's partly the child's responsibility. That's partly the parent's responsibility. And then sometimes they come back and they're like, oh no, it happens straight away, or no, like they'll actually then have the information that will allow you to make the diagnosis, rule it in or out at that time. And then I actually don't think very few people need an exercise test. Usually either history on the first time or history the second time once they've been asked to do some homework. Focusing on these key features is what you need. So hopefully that's been helpful. Catherine, I can see you've got your hand up.
Shiv, I just wanted to check. Some of the action plan have, take 2 puffs of Ventolin before you exercise if you get exercise-induced asthma. Just looking through the spirometry and the logic, would that still be helpful? Because it seems like symptoms just take a while before it kicks in.
Yeah, it definitely can help, because if we think about the effect of Ventolin, it can have some effect for a long period, like an hour or so, or even longer. So it definitely can help. So there are definitely some people who should have that, but also in someone with really bad exercise-induced asthma, they can break through that 2 puffs of Ventolin before sport. So And sometimes that people are religiously having 2 puffs of Ventolin before sport for no reason. So say, for example, like as in they'd be fine without it. So sometimes what I'll do is part of that homework challenge might be, okay, because it's not like I can often see them the next day or something. So often I'll say, well, you're going to go away, I'll be able to see you in 2 months or something like that, or whatever. Why don't for a month you just do sport without Ventolin beforehand? Like focus on these things, and I want to know what happened. And then for a month, do it with Ventolin beforehand. We'll see if there's any difference. And then you can piece it all together. So some people 2 puffs of Ventolin before sport is really helpful, and then and just to for people for adolescents with who use Symbicort or budesonide formoterol, I just say take 1 puff or 1 inhalation about 15 minutes before sport, and that's the equivalent advice. Do people have questions? Is that a framework that will help? Hopefully that's a framework that will help. Is it a problem people see? Is there any points of confusion? Yeah, does anyone want to clarify anything?
I think all the questions in the chat have been answered. I think it's really important, especially from all points of care, but especially in primary care at this time of year. I find it's really frequent that kids, especially the teenagers, will come in and say, oh, I take it a lot, when I exercise. And often something that I'll highlight to them is very few under 12s do a lot of significant exercise. I know they do a lot of running around, but kids by nature sort of run around, get breathless, stop, run around, get breathless, get stop. It tends to be in that teenage group who they've got more autonomy over their Ventolin use or Symbicort use, as it should be now. They're carrying it themselves. They're perceiving their symptoms more themselves. They've kind of got more insight into it, but also physically they're being asked to push themselves more. They're often doing more competitive sports, more team-based sports at school. And obviously children do that outside school, so it might come up earlier, but you're starting to be asked a bit more in physical education. So that's the time I find as a GP that I'm getting the teenagers coming in saying, oh, I need to, at that asthma plan review preschool, oh, I do need it for school, I need it for PE. And I think just asking those questions, saying, what does that look like, is really important in primary care to tease out, is this actually asthma?
Stephen, that's a good question. So it is hard. Like I tend to, a significant amount of exercise for me is like a good question that can be helpful to ask is like, I find, do you do cross country at school? And cross country is set at an age appropriate length. And so if they're like, yeah, I do cross country, then I say like, what happens with cross country? Like that's a good significant test of a child. Or I think of like a sport that involves a lot of running around. And so and then that's a good way to kind of age adjust it, if that makes sense. So, a footy game goes a lot shorter for little kids, but it's still like if most kids of that age will be able to complete the whole game rather than having to come off in the second half. Wei Cheng, easier to advise trying Ventolin before exercise than following up. So I get that that's very pragmatic. I guess the downside, and I don't work in GP practice, so I don't want to sound too dogmatic, but I guess the downside is that a lot of people might use Ventolin unnecessarily then, and it's kind of like a label. Yeah, they're using Ventolin when they might not need to. That would be my only point.
Yeah, I've actually de-diagnosed someone with asthma on exactly that history. Hasn't really used her Ventolin regularly in 7 years, just takes a puff before exercise, and she's 15. And actually, we did a bit of an exercise trial. She's not got asthma anymore. She's just been taking it out of habit. We've just had the hurry up message from the moderator, so I suppose we should move on.
Yeah, so, okay, I hope that's helpful. I'm going to stop sharing my slides, and then I think it's over to Kirsty to talk about action plans.
Yeah, so I'll just flip around here, screen sharing. So we were just going to go through a bit about asthma plans very briefly. It's mostly for the primary care physicians in the room, the asthma plans. So I don't know, can people see me and the screen? If you look at your box, can you see the actual picture of me? Great, okay. I don't know if I'm going to be able to do this, but if I just unblur that, sorry, this plan doesn't actually exist anymore, so I couldn't get an electronic copy. Can you see that? It says Asthma Action Plan, Victorian Schools. So most GPs will be familiar with this format, the traffic light system produced by Asthma Australia. Now, the reason for me showing that is if you've not been part of the community of practice or not been to the specific ones before, that Asthma Action Plan was actually removed. And it's a really important point because it's an ongoing issue with us being presented with this action plan to be filled out. Now, what's the big deal? Well, the decision was made to remove it in February last year because there's an ongoing confusion with asthma care due to the amount of paperwork and the differences in the paperwork that asthma patients and their parents get from different sectors. You're admitted to hospital and you get the hospital-based asthma plan. You go to school and you get presented with the Victorian Schools asthma plan. You come to the GP and they will do whatever asthma plan they have in the practice or is embedded in the service. The visual difference between the plans and the differing advice that comes with the plans can be really confusing, and that's what we've had fed back from our consumer members of the working group and through the community of practice, that the more clear and streamlined the information, the more likely it is that it's going to be followed and good asthma care is going to be given. Unfortunately, the asthma plans are a crucial part of asthma management and giving autonomy to parents and children, but it has become a bit of a piece of a paper, a form to be filled to allow kids to go to school. And that was never the intention. We're aware that schools have OH&S stipulations that they need to stand by, but as per the Department of Education, a child with asthma needs an asthma plan. That can be in black and white or colour, and it can be whatever asthma plan that they have pre-populated by their physician. Asthma plans do not expire. So if a child comes in being told your asthma plan's expired, you cannot attend school, you cannot attend daycare, that's not true. And the information is on the Department of Education website. The date at the top is a clinical review date for people to review the clinical condition of the child. Are they still asthmatic? Do they need an increase in care? And it's really vital that we have a review date that correlates with the clinical picture of the child. So it's not just an automatic review next year because that's when school starts again. It's like we used in the case studies. Actually, you need this reviewed in 3 months because we've made a significant change, and the maximum time interval I'm comfortable with seeing you again is 3 months. And practically, if you put 2 weeks, it can be difficult. So some advice for primary care, where if you have these Victorian, we're going to move to a poll and ask just while I'm chatting, how many people have actually been getting these Victorian school plans through the front door and asked to be filled out? The idea is we're trying to use this platform to communicate with the education sector and the Department of Education to show schools that this is not the model we want to be using. We want to be using a more robust version of the asthma action plans. So for those who haven't seen these, this is very much an asthma first aid plan, the Victorian Schools version. It isn't necessarily specific to the child's asthma care. So it's not of too much use to the parents. And it doesn't involve any data on the preventer and how to escalate and de-escalate care. So we felt that one plan for one child was the best across all sectors, was the best way to have continuity and compliance. So just a quick view there. We've had 16 people say that this year they've been given the Victorian Schools plan. So sometimes we get a bit of kickback about the plans. I've made a set piece letter that I print signposting to the Department of Education and the guidelines and the reasons why we're not using those plans. That's a practical thing to have in clinic. I know it's very easy to just sign it and get on to the next patient, but really the whole idea of this is to improve the asthma care of children, especially in West Melbourne, because statistically it is worse than other areas of the state. So I'm just going to quickly show you the asthma plans that we do use. I'm just going to have to stop screen sharing and share a different one. So we're here. So this is the Asthma Australia plan, if everybody can see that there. This is embedded in best practice. So if you're using best practice, it's very easy. If you go into your templates, it's there. It will save a copy to your notes for your records, and you can print a plan. It can be in black and white. I usually just print two, one for school, one for home. Practical measures, we say put it in a Polly Pocket, stick it in the fridge, take a photograph so it's on your phone, and then it's there for the babysitter, the grandparents, you on your own records, and the school can have a copy. This was also streamlined last year to be easier to use and easier to see. And you'll see there's sections there that say what well controlled is, flare up and severe, and emergency. What we want is good quality asthma plans, because we know that confers good quality of asthma care. And one of the things that we had was that you go from severe to emergency in the previous forms of the plan without any go-between. So almost suggested you could manage severe asthma at home, and then when the Ventolin stopped working, you called an ambulance. We wanted a mid-ground to allow parents to know that, hey, if Ventolin's not lasting 3 hours, you should be packing up a bag, giving the child Ventolin, and heading into emergency or your GP, urgent care centre, in a controlled fashion, not in an emergency. So you'll see that in the severe section, we now have reliever medicine not lasting 3 hours. That's severe asthma, okay? You should be giving the reliever, you should be heading to the GP, heading to the urgent care centre, heading to the emergency department, whichever one is available to you. So that was one of the major changes we made. I'll just show you the NEC plan as well, if I can get it up, which I can't seem to. Give me 2 seconds. This is the Health Pathways website, which we'll go through. So Melbourne Health Pathways, you can access all these plans and guidelines for how to use the Symbicort plans in over 12s. This is the age 6 to 11 section. And if you go down, you can use management, additional management, asthma action plans. A fix we'll have to do is the Asthma Australia. Maybe Kevin can speak to that in the Health Pathways team. The Asthma Australia one isn't on here, but the National Asthma Council Action Plan is there that you can access following that link. And the again, apologies for my IT skills here. The Symbicort action plans are also there. I'll just show them for anybody who might not be so familiar with them. That's an example of the Symbicort action plan. Now, again, I've lost access to the chat. It looks like there's some questions there. Does anybody have any practical questions and practice difficulties they're having with the asthma plans? Some really good things here. Narelle from National Asthma Council has put up the links to their asthma programs. If anybody wants to take those links down, again, they'll be sent out. Anna Marie who's one of our great consumer representatives, saying that the Melbourne Catholic schools have added another medication authority form that has to be co-signed. I've had that as well. That's just a simple authority form to say that the school is allowed to give that. Someone asking which plan to use. I use the Asthma Australia one. It's the one I'm used to. Use the plan you're used to, one you're familiar with, and it's the one that's embedded in my best practice. Kevin from Asthma Australia saying it's embedded in medical director as well. Wei Cheng is saying, I saw one from the ASCAI, especially those needing an anaphylaxis. This one's okay. The anaphylaxis action plan is something slightly different. So the guidance from the Department of Education, that is the only anaphylaxis EpiPen plan that is allowed. So it is the only acceptable one. It's also the only good one I know that's in existence. I'm happy to be corrected on that. The difference in asthma care and on the slight issues, which is an ongoing discussion for our working group, is the number of asthma plans, like I said. So the best asthma plan is the one that works for the patient and yourself, the one that is of good quality, and the one that is patient-centric. Now, there's asthma plans in a multitude of languages available through the Asthma Australia website and the NEC website. So be mindful if you work in an area that has a high proportion of patients with English as a second language, to ask your patients if they want one for home that is translated into their language. Both the NEC and Asthma Australia have fantastic resources regarding asthma in people's own language. So that's another resource for your patients. Just another couple of questions. Stephen saying, classical case I see all the time. Only difference is the patient usually does not turn up. Only the mother or the father via telehealth with the patient. Yeah, tick box by required or school. Yeah. So Rachel saying how common this is. I see it daily in practice. And I think one of the problems with the plans are needed. They're necessary. They're not going anywhere. But it's become a devolution of care. And again, the feedback from our consumer representatives is we pass on the plan, and the feeling is almost that's it, that's what you're getting. That's how you manage your child's asthma. We'll see you next year. And it's not the message we're trying to convey. And really, when someone phones up, so I had this yesterday in practice, and says, hey, I've got my 2 boys, can you do their asthma plans? I haven't seen these children in 6 months. I've not reviewed their asthma technique. I suspect one, their inhaler technique, I suspect one has outgrown the diagnosis, and I expect the other one needs an escalation in care. I actually declined to do the plan. And I think a really good thing to be able to be firm in your boundaries and say, I'm not actually going to do the plan. Your plan from last year does not expire. They can attend school. Now, often people won't turn up again. And I never want a patient to attend because they're being hassled for paperwork by the school, but sometimes that is the reason why they come back. And at a point of contact where you have the patient and the parent face to face, you can explain the difficulties, and the paperwork is not a tick box exercise for yourself or them or for the school. It's a really important clinical tool to help them gain the confidence in managing their child's asthma. But unfortunately, in modern day GP practice, it's presented at the end of a long clinic appointment. Oh, can you just sign this? It's handed into reception. Can the doctor do that? It's called in. And my answer is actually no, I can't do it, because me doing that piece of paper does not change the child's clinical care at all on that day. But them coming back and seeing me and doing a clinical review does. So I see it as a piece of paper that's really important when done well, but if it's just a box that ticks, it really has no purpose other than to satisfy a need for school, which doesn't actually satisfy the need because it doesn't actually help them manage the child's asthma. Anybody else have opinions on that? I'm relatively opinionated on it, so happy to take other people's opinions.
No, I'd agree. I think it's action plan is a really powerful tool when the goal is empowering families to manage the condition, and it's a really useless tool when the goal is ticking an admin box.
Yeah.
And yeah.
Sorry, just a really good question here saying from Nithya, for the school request by parents, we just have to fill in the Victorian school one for the parents' own use. They can either use the Asthma Australia National Asthma Council, is that right? Not quite, so sorry if I wasn't clear. The purpose of showing the Victorian schools one was to say, if this comes across your desk, you take it, you fold it up, and you pop it in the shredder, and you say, we don't use these anymore, actually, okay? So the Victorian Schools Asthma Plan, if you actually look at it, is just a first aid advice poster, and schools are trained in first aid. What the idea behind the asthma plan is to manage a child's asthma. And it becomes really confusing for parents and patients when they have a schools plan and the one for home. And it sounds so simple when I say it like that. But if you have one asthma plan that you have and you print out and you follow it, it makes things much clearer. And that's the feedback we've had from all the consumers we've involved in these studies, is that there's too much confusion, there's too much communication. Asthma is always something that I think healthcare professionals think is relatively easy. It's one of the first things you tick off. It's sort of oh, it's asthma, I can do this. But it's nuanced, and it's nuanced in the history, it's nuanced in the presentation. And for parents and patients, they're not, and schools, they're not healthcare professionals. So just giving them a first aid poster doesn't really attend to the child's, the parents, or the school's needs. It's just become part of healthcare culture that that's what we used. Victoria was the only state that used school action plans. None of the other states have them. So we want one plan for one child, not lots of plans. Hope that's clear. Okay, I think we have to move on. I'm being a chatty Kathy again. Right, I'm going to try and stop screen sharing.
I think the next section is about talking about communication between the health and education sector. And so I think the plan for that was for it to be very open. And I guess we're specifically talking about with regards to childhood asthma, because I'm sure there's lots of aspects of health that intersects with education. But I guess I'm not sure if we have anyone, any people from the education sector or school nurses or people who work for the Department of Education who've joined, who maybe want to talk about, who want to highlight some of the challenges they have looking after asthma in their sector.
While people are picking up the courage to chat through that, this was just a 5-minute sort of section to bring up any issues. One of the cultures of the community of practice is to have a really open sharing information, and schools are so important in the care of our children's asthma and communication. We've been working behind the scenes with working group trying to figure out how to involve that, and I know we have representatives of the Department of Education here tonight, so they can take any questions on pause and they will try and find answers. So if you have any suggestions or thoughts on how we can improve care and collaboration with schools. We had some questions through from some asthma nurses via one of our amazing asthma nurses. And some of the things they had highlighted was healthcare professionals using different templates and plans, and it can be confusing. So that's what we were just discussing, and we are working on we're thinking about one asthma plan in the same way there's one anaphylaxis plan, but that's a work in progress. Ideas for schools and things that if we have parents of asthma children here, is school having medication bags, like a grab bag in sick bay to store the plans and medication for each child, for those who don't carry their own inhalers. Things for GPs to remember when you are prescribing, and this just as an aside goes for EpiPens as well, making sure that the medication's in date and checked when you see them, and that they're getting medication with a long lead time. I've had patients prescribe EpiPens that only have a month left, and then they come back and have to pay for it again, so checking expiry dates, and that's something you can advocate patients looking after. And just making sure that if you have an asthmatic patient who's not presenting with an asthma plan, to let them know that they do need to let school know. One of the suggestions was building more of a relationship like we're trying to do between GPs and schools, to have direct contact between the schools so we can just forward on an asthma plan without sort of bypassing the patient and the parent. But Shiv and I discussed this, and we're pretty against that, just because the whole idea is that it definitely facilitates the paperwork being done, but it completely avoids the point of it, which is to check up on those kids. And it's not always, as I give a couple of examples, it's not always to increase the care. Sometimes it's to undiagnose. I've written 3 letters this week of this child is no longer asthmatic, they don't need to keep coming back in for their plan. Stephen said it would be great if there was one hub or website with asthma instead of the RCH website, National Asthma Handbook, Handbook Australia. Funny you should say that, Stephen. What a nice segue. We'll keep taking questions or thoughts about the education sector, how we could improve communication with our school nurses. I'll just share my screen here, if I can go to health pathways again. So if you are in our district, this is the Health Pathways website, so Melbourne Health Pathways, and if you don't have access to Ask Your Practice Manager, they'll be able to get you onto it. Along here, it has every health pathway for referral protocols, And you'll see in child, there is respiratory child, asthma in children, acute asthma in children. If you have an asthmatic in the practice and you're not used to it, it's been a while. If it's been 4 years since you did an acute asthma attack, there's really good guidelines there. And then it's broken down into asthma in adolescents, primary school age children, and wheeze and asthma in preschool children, age 1 to 5. Briefly, the asthma has changed, pediatric asthma has changed. The over 12s will represent the new Symbicort advice, so that's using it as required and as a preventer reliever. 6 to 11 hasn't changed as much, but there's some good guidance in there. And the main change for the preschool children is in nomenclature. We no longer use weather wheeze or viral induced wheeze, we say asthma. And again, that's for consistency in messaging for parents. Parents, again, this is from feedback, get distressed and confused when they go to hospital and they say, oh, it's just a virus. They go to a GP and say, oh, this is asthma. They go to someone else and says, this is viral induced wheeze. It's asthma. If your child's wheezing, they have an asthmatic tendency. Let's just call it what it is. It's asthma. We're going to treat it like asthma. It's asthma. That obviously excludes the under ones, which is why it says 1 to 5, where we're looking more at bronchiolitis type pictures. The other major change for preschool children is not using oral steroid in the community. There is no evidence for oral steroid in the community. Oral steroid is evidence to prevent a child ending up in intensive care. If a child needs oral steroid, they should be in a hospital setting. Very tempting to use, but a lot more advocacy for starting preventers early in these children if they need a lot of oral steroids, as opposed to continually giving them oral steroids. And then I think, sorry, I'm going to have to do this clunky way again. I think just the last screen was to talk about the community asthma programme. The community asthma programme I mentioned in my case studies. This is a DHHS funded service provided by DPV Health and Co-Health, depending on what area you are. They provide free asthma education and reviews for all children under 18 in the area. It is an invaluable service to my care. They can be included on an asthma GP management plan as one of the care providers. Their availability is usually seeing the child within a week. So the example would be a child comes in for their asthma plan, you review, you feel that the education isn't there, the control's not there, there's something that's needing extra space. And time, as you said, we're busy. Sometimes they don't want to come back. Sometimes you're booked up for a few weeks. You make a referral through the community asthma programme. The referral is embedded within best practice. And they will contact the patient usually within the first week and often get them in for an hour-long appointment. They do everything I can do and more. They have the ability to have group sessions with local families who have asthma. They have the ability to go into daycare and schools to educate and visit the patient's home to look for environmental triggers and troubleshoot if you have any consumers who are in a hard to reach situation. I've been using them for over a year now. It's one of the best communication links I have with any healthcare provider. It's the most education I get other than this forum. And I really cannot speak highly enough of the nurses that work there. Co-Health Laverton also has a nurse practitioner who can do more advanced care and triaging of any child with asthma. Happy to take any questions about that. Having a look at these questions, have you picked out anything here, Shiv?
Yeah, I was just saying about, I think there's been a couple of comments about the asthma handbook, and I was just saying that we've specifically designed the health pathways and clinical practice guidelines to be really concise and user-friendly, to kind of be a bit more efficient than asthma handbook. Narelle commented that the handbook's being revamped, but I'd still encourage people to use the health pathways and CPGs, because this is just, we're specifically trying to harmonize asthma management in our area, whereas the asthma handbook kind of talks about all the different ways asthma can be managed. We're trying to promote one way that asthma can be managed so that there's harmony between GPs, emergency departments, and hospitals. And so that's why I'd really encourage people to use the health pathways and the CPG so that we all do it the same way, and hopefully it's quite easy to use. And then there was a comment about the role of Ventolin in people without asthma. And I said and whether you just keep giving it. So Ventolin will only help people with asthma. So really try to stop it if you don't think that it's being helpful. Sometimes that can take a few visits to achieve and work out if you think it's helpful or not. And sometimes you need help from other people in that assessment.
The only one I would say there is children with anaphylaxis. So they're the only ones. Obviously, Ventolin does help, because there's a couple of questions about Montelukast for allergies as well. Montelukast for allergies, I put it on the allergy plan. So the ASCAI have an allergy plan. So I would put Montelukast for allergies on that, along with antihistamines and nasal steroid. And if the only non-asthmatics that I will give an asthma plan to with Ventolin is the anaphylactic kids, because obviously they can wheeze, and for some reason, even though there's a box to tick saying they have Ventolin, they still need the asthma plan. And I think, look at the risk there. If you've got anaphylaxis, the risk is there. Thunderstorm event, you never know. They're the only ones that I'm like, yeah, sure, you get a Ventolin on an asthma plan. You get it for free.
And then Stephen said the paper copy of the asthma handbook. I'd just say the danger with paper copies, well, there's two things why I'd still encourage you to use health pathways or the CPG, Stephen. One is the previous copy about a comment about consistency of care in the inner west of Melbourne that we're trying to promote. The second comment is about paper copies unfortunately becoming obsolete pretty quickly these days. And asthma is continuously changing and evolving. So I'd be interested what the paper, depending on how old it is, for example, the paper copy might not talk about budesonide, formoterol, or Symbicort in the over 12s. So, yeah.
And I would agree with Stephen, there is too many websites. Really, my main ones are the children's or health pathways. I know they're both up to date. They've both got the most useful guidelines on them. I probably use the Royal Children's a little bit more, just because I have it open for patient information leaflets most of the day anyway. But if you're ever thinking about how to step up therapy, which age range has that one changed, because that happens, it's got really clear stepwise management, and they're the two I would use. Asthma Australia is brilliant, NEC is brilliant, but practically I think you find which one you're familiar with and you use that one, because otherwise it does get confusing.
And just one last point on that, we've kind of said health pathways and CPGs a lot. We've worked together to make sure that information is the same, so they're the equivalent information. So just choose whichever one is easy for you to access.
Yeah, one
isn't better than the other; they're the same.
Great. I think that's it. So we just had a quick poll. If anybody it's an ongoing thing. We're looking to see if people are actually referring to the community asthma program. One of the measurable outcomes from the ICAM project is to see if referrals to the community asthma program are increasing. Currently, they have loads of capacity, correct me if I'm wrong, but as of this afternoon, it was still confirmed they had loads of capacity. So use them. It will be the best resource you can. Patients really engaged with it. They love the time and attention they get. The nurses who work there ring you, they email you, they will send paperwork, not in an onerous, too much work way, in a really useful, educational, clinically relevant way. I've referred lots of patients this year, some of whom have now officially been discharged, and the feedback that you get from patients is really incredible. And even more importantly, these kids who were bouncing in and out of ED with every infection, every weather change, they're not going anymore. So it's great to see. It's just anecdotal from our practice, but great. So yeah, people have made referrals and no, but likely to make referrals in the future. And for whoever wrote no, not likely to make referrals in the future, we'd love to know why as well. If you want to email us and feedback, if there's things about the service that would make you not use it, we'd love to help improve everything.
I think So I think that brings us pretty much to a close. So maybe, Kirsty, would you mind going to the next slide, please?
Yeah.
I think there might, so we'd really love as much feedback as possible. Hopefully you found today useful. Thanks so much for the engagement. I think the polls and the chat has been the busiest we've had. So really thankful for that. We'll go to the next slide, please. I think if you wouldn't mind either clicking on this link or scanning the QR code, it's an opportunity for feedback, and we'd really appreciate that because we're here to run sessions that are useful for you. So please let us know. And then I think with a minute to go on the last slide, our next community of practice, which is in late March. And then the very last slide, I don't know, Kevin, if you want to talk to this, it's about a competition for Asthma Australia.
Yeah, thanks, Shiv. Good evening, everybody. I'd just like to alert you to, we've got a fantastic competition running at the moment for people with asthma. There's no real hoops to jump through. It's really, you've just got to fill in an application to win one of these 20 air purifiers. Also, schools can we have another competition going for schools as well, where they can win an asthma first aid kit. So certainly spread this and direct it to your patients. Happy for them to come on board. It's been very successful so far, the response we've got. We've got about 5,000 entries so far. So yeah, there's a lot of competition for those air purifiers. But yeah, please ask people to go onto our website and enter. Thanks.
Whilst Kevin's there, I would say as well, if anybody has any suggestions or any difficulty they've been having between, not difficulty, but troubleshooting they've been having between the education and healthcare sector, a common one is having the wrong plans sent through or lack of communication. Kevin has offered previously, if there's schools that you feel could help or benefit from Asthma Australia, chatting to them about asthma plans, about asthma care, and that's another service that a lot of the asthma services can provide. So if there is any issues, points that you think could be improved on, great relationships that you have with your local school, we would love to know about that, because we are trying to foster a relationship where we can support schools so they feel less alone and confused by our often confusing information. So if anybody has any points on that, please feel free to email us.
Great. So I think that brings us to a close right on 8 o'clock. Thanks everyone for your time. If we could just request that the members of the organising committee stay on the line so we can have a quick chat. But everyone else, thanks and have a great night.